Hello, my name is Dr. Neil Sharma. I'm an interventional endoscopist at Parkview Health. I'm the program director for our Interventional Endoscopy Fellowship. I'm also the director of our Interventional Oncology and Surgical Endoscopy programs for Parkview Health, as well as the president of our Parkview Cancer Institute. I'm here to talk to you today about an upcoming article in the February issue of Gastrointestinal Endoscopy. It's entitled Flexible Diverticulotomy for Zenker's Top Tips. This is a single author special edition article on top tips to approach Zenker's diverticulum with flexible surgical endoscopy. I've performed over 100 of these procedures and modified my technique over the years as new tools and tips have become available to myself. I've worked very closely with ear, nose, and throat colleagues as well as other interventional endoscopists to be able to refine our technique. I hope that this article can provide you a sound approach to endoscopic diverticulotomy using flexible surgical endoscopes. The purpose of our Top Tips series from gastrointestinal endoscopy is to provide expert opinions that will be an approachable article, very easy to read, and allow you to help modify and or refine your technique to get the best possible outcome for your patients. Zenker's diverticulum is a rather rare disease. It's an incidence of less than 1 in 100,000 patients and has a higher prevalence in the elderly population, most often seen in patients between the ages of 60s to their 80s. Some patients may have no symptoms at all, so typically we ask you to meet the patients, have a good history and physical examination, and calculate an Eckhart score before you approach the patient. Once you recognize a patient having significant symptomology from a Zenker's diverticulum, you can then further determine the best approach for treatment of this disease. In the past, Zenker's diverticulum were often approached with an open left neck incision. However, as techniques and technologies modified through a period of time, we were able to take more often transoral approaches. Our article highlights transoral approaches done by flexible surgical endoscopy using a flexible endoscope. Originally, transoral approaches were performed by ear, nose, and throat, as well as general surgeons, with a rigid device that often implemented a rigid stapler and hyperextension of the neck. Now, with flexible surgical endoscopes and utilization of new endoscopic knives, we're able to refine this technique even further for better outcomes and to approach complex Zenker's diverticulum that perhaps otherwise were left only moderately or not able to be treated. It's important to understand that Zenker's diverticulum is a propulsion diverticulum. It's located posterior to the esophagus, and it's within Killian's triangle. It accounts for about 70% of all esophageal diverticula. However, diverticula can occur in an anterior lateral approach, such as a Killian-Jabison diverticulum, or can occur in the distal esophagus as well. Zenker's diverticulum, as I mentioned previously, is uncommon. It happens more often in the elderly population and should be treated when symptomatic for patients. It's thought that this diverticulum occurs through a propulsion defect and there's impaired relaxation of the cricopharyngeal muscle. When we're performing a diverticulotomy, it's different than a diverticulectomy. A diverticulectomy, often done through the open neck approach, will remove the pouch altogether. In the case of flexible surgical endoscopy, we're able to cut the cricopharyngeal muscle, performing a diverticulotomy. This allows for relaxation of that area and transition of food without retention of the bolus within the Zenker's pouch. We're essentially improving bolus flow across the cricopharyngeal muscle, decreasing outflow obstruction, and overall potentially mitigating aspiration risks that are often seen in these patients. As mentioned previously, these oral approaches have continued to be refined. In the article, we do talk about the best approaches using Zenker's diverticulotomy with flexible surgical knives. We discuss some of the optimal knives to utilize, other devices that may or may not come into play, and then we also touch upon a newer technique called Z-POEM, where we're using a tunneling technique very similar to esophageal per-oral endoscopic myotomy. I hope you find the tips and tricks useful. Feel free to contact GIE or myself with any additional questions, and this hopefully will help you improve the outcomes for your patients who you approach with Zenker's diverticulum. Thank you.